I'm sure that you're getting sick of listening to me. Okay, so we'll be fine. Oh, okay, so dysmenorrhea and endometriosis. And we'll talk about dysmenorrhea more generally, and then go into endometriosis. So hopefully you'll understand all these things by the time we're done. I'm probably not going to read them all right now. Okay, so dysmenorrhea. This is when a patient comes in and they have really severe, very, very severe and painful periods. They might have just what feels like a lot of pressure, or they might, and it might cause them to feel very ill, like have systemic symptoms almost that seems out of proportion. They'll have sometimes tachycardia, they can have nausea, they can have syncope, they can even have GI symptoms where they have nausea, they have diarrhea. And this is all occurring just before or right during the time when they have their period. If that happens when they're young, they start having painful periods from the beginning, and we don't see any reason why this is happening. We can't identify any pathology to attribute this to. We consider that primary dysmenorrhea. Now, if it happens later, like they have some time to develop possibly some conditions that could cause that, and we can figure out what that is, and that's secondary dysmenorrhea. So primary dysmenorrhea, this is usually we think this is due to prostaglandins, and whenever some prostaglandins, not all of them, but F2 alpha, this increases uterine contractility, so whenever they're having their periods, they'll just have more cramps, and they will be stronger than anyone would like them to be. And the first line treatment for that is your NSAIDs, because they block the prostaglandin synthesis. So, and other treatments are birth control pills, just so that they don't actually have periods a lot of times. Those are the patients that are really good candidates for having the continuous pills, where we either have it every 3 months, or sometimes not at all, or like before an IUD, so they don't have periods anymore. Secondary, and we'll go through some of these, and some of these are related to endometriosis as well, or cause endometriosis, but cervical stenosis, endometriosis and adenomyosis, pelvic infections, always consider that because we can treat it and make it go away a lot easier than some of these others. Adhesions and pelvic congestion and stress and tension. So cervical stenosis is when you have narrowing of the cervical canal. Not just the os, but usually the entire canal, and it keeps menstrual flow from flowing usually the right direction. They have more backflow, which becomes a problem from them in the end. It can lead to endometriosis, and it can happen just they're born that way, and it can happen as a secondarily to other things that happen. But basically it increases the intrauterine pressure because that blood cannot flow out. And like I said, it can lead to endometriosis, which I'll talk about the pathogenesis of that here in a little bit. Secondary, with cervical stenosis, usually these patients will show up with scant menstrual flow because they might have flow that needs to come out, but it can't, so it's not going to be really heavy. They'll just have periods, they might go on longer than they really should, and they'll have a lot of cramping. Whenever you do an exam, you might find that the cervical os is very tiny, and many times they can't sound it very easily with the cervical sound, and those patients need to have cervical dilation via DNC or laminaria placement. So, do you guys want to know what a laminaria is? We gone over that? Because it's fascinating. These are things that happen, and I'm like, who thought to do that? So, a laminaria is actually seaweed. It's actually seaweed that they wrap around a rod, and it absorbs water. And so, they go in, and it's just, they use did I have? Okay, no, I didn't. They use just a speculum. And then they go in, they might sound a little bit they might sound the cervix, but then they place this laminaria, which has a rod with seaweed wrapped around it, and they leave it there overnight. And during that time, it absorbs water, and I know, it's weird, and gets larger, and slowly, and less, I'm trying to think of another word that's not like, but anyway, it's a little easier than just doing a D&C. And usually they have to do it before they do a D&C, you'll have a lemon area placement. Especially, most people who are getting a D&C have possibly some cervical stenosis, and so they won't do one without the lemon area placement unless it's for like a pregnancy-related situation. But anyway, they'll leave it there for 12 hours and then proceed with the D&C sometimes, or oftentimes not. Sometimes the lemon area is just the treatment itself. But it's very odd. I actually sent a text to my friend who's an OBGYN and was like, who came up with the lemon area thing? That is weird. And she was like, she said, I have no idea, and I've never thought to ask. So I was like, okay, that's just me. I think it's weird. We thought CBD was a good idea, but they didn't. Okay, so pelvic congestion, where you have, so this is due to pelvic vasculature that gets congested. So they could become tortuous, the veins. And during the time when they have their period, those varicosities become larger, and so usually they'll have a throbbing pain that is worse. If they've been standing for a long time, certainly after standing a long time, and then at night they'll feel that throbbing pain that goes along with that. And usually you'll see that on hysteroscopy. So whenever somebody comes in and they have pelvic pain, you want to find out the detailed history, right? Like which kind of bleeding they're having associated with it. Are they having such heavy bleeding that we need to consider whether or not they're stable? And then, so you do a lot of the same things. You'll always get an HCG, a CBC. Consider that there could be other causes, or this, if it were something like endometriosis, it could affect other organs, and so you have to consider that. And then your big 8. Do you guys use old car for your big 8? Old carts. Old carts. Okay. It's the same questions. And then your risk factors, and then always consider gyne and non-gyne causes. So this is your differential diagnosis for the gyne causes. For dysmenorrhea, it could be the uterus, right? They could have the same things that cause AUB, the fibroids, adenomyosis, or endometriosis. It could be their fallopian tubes. They could have an infection. Or hydrosalpinx, which is basically where you have fluid that builds up in the fallopian tubes, and then it usually happens in both fallopian tubes at the same time, many times, but basically it builds up pressure, or an ectopic pregnancy. There could have some ovarian cysts, and they could have a tubo-ovarian abscess, which is what TOA is, just so you know, torsion, or just middle smarts. But that doesn't usually happen right then. But endometriosis, adhesions, could just be an IUD can cause that kind of pain, and prolapse. So then there's also these urologic causes of pelvic pain. They're non-gyne that you have to consider. Do they just have a UTI? Do they have interstitial cystitis, which is pretty common? Do they have overactive bladder? Or some urine stretching, constipation, IBS, PD. There's lots of different things that can cause pelvic pain, so you have to consider these things too. And you rule this out. How are you going to rule these things out? A good history. Is that what somebody said? I love that answer. It's really beautiful. That's good. Okay, so you want to consider all the factors when you're treating a patient, because this is it really affects their life, at least for some period of their time, every month, right? So they've got like a week that they have to dread coming up. So consider what the things they like to do, is it affecting the way they play sports, things like that, and your treatment. NSAIDs, right, are your first line, possibly OCPs. You want to increase, get them exercising. We need to start considering their mental health whenever you see these patients as well. Because any chronic condition like this is going to start affecting that. You can start to have some anxiety associated with this thing that's coming up. And really just try to focus on, anytime you can give somebody objective measures for knowing they're improving, it's very helpful. I think it's why so many people do well with things like diabetes, because we have metrics that we can give them and we can say, you're improving, you're doing well. And so one of the things you can do when you're talking with patients about their treatment plan is come up with things that they can know they're doing well. Like, you need to, on days when you're having your period, I want you to get out and do this. If you're still working out the whole time, then that's a good thing. That means we're making some improvement. And that way they can go back and feel a little bit better about their treatment and know that they're getting better, that it's improving. Okay, endometriosis. So this is where you have endometrium-like tissue, epithelium and stroma, outside of the endometrium, right? So it's endometrial tissue that now is no longer there. It's traveled outside, and it can happen lots of different places. It can happen superficially on the peritoneum. That's peritoneal endometriosis, and it can extend below the peritoneum, the deep endometriosis, or it can be on the ovaries in the form of an endometriotic cyst, an endometrioma. These are all places where you can have endometriosis. So you can have it on your urethra, you can have it on your bladder, your GI tract. It can affect all these different organs detrimentally. And this is a lot of people. It was an international study with over 2,000 patients. And where they see it the most is it affects their sexual health, their family relationships, the way they interact with people that they care about, how they can succeed in school, which affects their earning potential later on in life, and it affects and then their fertility later on too as well. It's pretty common, and it's becoming more common, unfortunately, is what we think. You know, sometimes whenever prevalence goes up in certain conditions, we think, is it really going up, or are we just diagnosing it more? And we think with endometriosis, it actually is going up. It's not just that we have better methods of seeing it. We're not sure why. We think perhaps it's because kind of OCPs and hormonal birth controls have sort of fallen out of grace in some ways, and they're actually using them a little less often than we used to per capita, and people are having more periods. People are having more periods because they're using less OCPs or other hormonal contraceptions, but they're also just not having children until later on in life and having less children. And so when that goes on, you're having more periods. And anytime you have more periods, you're at an increased risk for endometriosis. So here's the theory of pathogenesis of endometriosis. The big one, and you really don't have to focus a whole lot on these other ones really, because Samsons is the one that's won out, honestly. So Samsons Theory is that endometrial fragments, just so you know, since the 1920s, that's when we started doing surgeries, right, on a regular basis, and safely. And they noticed during that time that women would, on their periods, they would have blood that flowed upwards through the uterus, in and out the fallopian tubes, out the ovaries, into their peritoneal cavity. That was happening. It just didn't occur to them before, like that could happen. And it does happen. And it happens to just about every woman. It's just something that happens, right? I know. And it's okay. It's all right. Usually it's okay. But sometimes, and so the reason why, so this is a pretty common occurrence, but it is, they think, part of the reason why this happens. But why does it happen? Why does it happen in some women? Some women get endometriosis, and they have retrograde flow, and some women have retrograde flow and they don't have endometriosis. So they think there has to be some sort of cellular component that changes in their tissue. Maybe they produce more prostaglandins or more cytokines, and that something like that happens with that tissue, allows it to adhere to these organs outside the endometrium that's harmful to them. But retrograde menstruation is important to know because if we can control, especially those people who have heavy menstrual periods, if we can control their periods, they have less of them, then we can decrease their chances of developing more endometrial tissue and lesions later on as they go through life. So, and it explains why we get it, except that there is a missing piece with this metaplastic transformation that Myers theory is probably some sort of marriage of the two. So these patients have severe menstrual pain. They have pain with intercourse many times that it's deep. And it's something it's useful to ask that. Whenever someone comes and they say they have dyspareunia, you have to ask, right? You have to ask, well, is it right at the beginning, or is it deep? Is it pain? Are you feeling it just at first, or the whole way through, basically? Sometimes patients get really uncomfortable when I get too specific about that, but they'll answer that question. And so, because if it is happening the whole way, the whole way through intercourse, then that's deep dyspareunia, and we need to consider that they might have some endometriosis lesions. Usually they have chronic pelvic pain, and they may have some GI symptoms as well. Now, there is no pathognomonic. There is no one symptom that's going to help you with endometriosis. It's kind of a collection of symptoms and a picture of the patient that's going to help you with that. The definitive way to diagnose endometriosis is laparoscopy. That is the gold standard. You look at it, you see it, you know you have endometriosis. It is not always a lot of people have endometriosis for a long time before they do the laparoscopy, and so they determine that it's usually 7 years before they're actually diagnosed definitively, by the time they have symptoms for 7 years before they die. So here's the normal uterus and fallopian tubes there. They're both shiny on this, but here's normal right here. And then where you see the endometrial lesions, usually it's the adhesions. It's the adhesions you see. Sometimes, I'm not sure if I included a picture that had a nice dark lesion. Sometimes, no, I don't see one. But you see, this is bowel right here. And so the adhesions, it's stuck to that area, and that becomes really quite painful. So you're diagnosed by the histology, but if you get histology and it's not there, it doesn't necessarily mean that it's not endometriosis as well. So you can't always say that, you can't necessarily rule it out as much as you can rule it in. And if usually, you don't necessarily always have to clear, they'd like to, if you're at the point where you're doing a laparoscopy, they'll try to go in and clear everything out. And especially if it's large on the ovary, if you have an endometrioma that's very large, you have to do histology on that. So they will take that. They won't do histology on everything they clear out of the cavity, but they will do histology on anything in the ovarian growth that's larger than 4 centimeters. So transvaginal ultrasound is just not terribly useful in this. Sometimes it's useful when you want to evaluate the ovaries, if you want to see any cysts or endometriomas on the ovaries, but it's not very good at picking up the adhesions that you see with endometriosis, so it's not terribly useful. Really, laparoscopy is what you need. So management, whenever you're thinking about how to treat endometriosis, you need to consider how significant it is, what's the extent, is it affecting other organs, does this person want to have children in the future, are they done with having babies, and their age. So first line treatment, and usually you try for at least 3 to 6 weeks, is NSAIDs and OCPs to control their periods, and progestins. And then, whenever you've decided these have failed over 3 to 6 months, you need to consider laparoscopy whenever we're going to go on to other treatments. Because some of these other treatments, Mirena oftentimes they will do, but I wouldn't do a Mirena until you get a laparoscopy on somebody that you assume might have endometriosis. Lupron, always do a laparoscopy first. This has a lot of side effects where they have hot flashes, vaginismus, and bone loss. You're putting them, they're having an early menopause, so they'll have those symptoms that go along with that. And then high-dose progestins, they also suppress estrogen release, and so that's how they help. And danazol, where they suppress LH and FSH. They also give the gain weight, hirsutism, acne, things that go along that you would see in a PCOS. So fertility preserving, which is important for so many of these patients, especially young people who have this, you want to go ahead and get a laparoscopy as soon as possible if you suspect that it's significant disease, so they can look at that and excise the endometrial implants. And then if most effective treatment for endometriosis is hysterectomy. Once you no longer have a uterus, and certainly no ovaries, if you get those out, then you do not have, if they are able to clear out all the tissue, you will not have a recurrence. So these other ones, even the laparoscopy where you go through, they can recur, right? So if you're going to do a laparoscopy, someone who is who wants to retain their fertility, you have to make sure you protect them. Whenever they're not trying to get pregnant, they need to be on something to control their periods. All right, that went fast. Okay, do you guys have any questions? Yes?
I have just one. Back in regards to the abnormal uterine bleeding, whenever making that classification of the ruling everything out and it was an endometrial cause versus something that was non-classifiable, how do you make that distinction between the two?
Oh, between something, you don't. Because you don't know what it is yet until you determine which one, you know what I mean? So, don't worry about that. That's like minutia splitting hairs. Don't worry about that. Yeah.
In a primary care setting, when do you think it's appropriate to refer to OB when you first diagnose?
Okay, so that's a great question, and I think for one thing, it depends on your comfort level with things. If a patient comes in and you know immediately that an IUD is the right answer for them and you are not willing to place an IUD, you need to refer right away. So it really depends on where your training level and comfort is with the treatments that are available to them. If you feel like you cannot offer them a treatment plan that could be helpful and could improve their quality of life, refer immediately. If you find that you want to go through a trial, maybe 2 or 3 months to see if it will improve, sometimes we'll do that, like a patient's naive to birth control, and they're really not interested in having an IUD, like I offer it, they're not willing to, then I'll say, okay, we'll try OCPs, we'll do that for 2 or 3 months, follow up closely, if they're not improving, send them. Or if they say, that was great, I'd really like to consider, that was really wonderful, not feeling like crap, I'd like to have an IUD. I was like, okay, let's do it, you know, but I feel that's something I could do, but I would say send them immediately if you're not. So, okay.